Sounds great. Well, thank you everyone for joining the Q&A with the doctor session. Happy to be the moderator here. My name is Tyler Harrington. I'm one of the Boston committee members. I got involved with Tina's Wish several years ago now. Let's see, my mom passed away of ovarian cancer in 2014, and my family and I have been at least trying to be as active as possible in helping fundraise for early detection of ovarian cancer. We've started an annual golf tournament, opened it up to friends, family, and actually it's growing in terms of work, colleagues, and friends. And that's actually how I got introduced to Tina's Wish. So shout out to Sandra, who's on here, and Julia Frost Davies as well for getting me involved in Tina's Wish. I'm not sure if Julia's in this room or not. But I honestly went to one dinner, knew I wanted to get involved, but then heard Dr. Elias at this dinner, and it's honestly just fascinating hearing the updates they gave already today, in addition to more information we'll get here through the Q&A. It's been a great organization to be a part of. So thanks to Tina's Wish for having me involved. And before we get started on the Q&A, exciting news on the update for the Brossman family match. We're now at $8,100, which is incredible. And the link's been given out already several times, but tonight we're obviously trying to raise as much money as possible, and it's not too late to donate. So please either click the link in the chat that was provided earlier, or again, it's tinaswish.org/BostonMatch to add to the fundraising momentum here. We ask that you think of all the women that could benefit from this amazing research: mothers, daughters, wives, sisters, and friends. And as noted in the introduction, early detection tests for ovarian cancer has the potential to save up to 150,000 lives per year. So we do certainly appreciate the support from everyone. Now it's my honor to introduce and reintroduce from the main session Dr. Dipanjan Chowdhury from Dana-Farber Cancer Institute, Dr. Kevin Elias from Brigham and Women's Hospital, and not part of the main session, but joining us now, Dr. Joyce Liu, medical oncologist and director of clinical research for the Division of Gynecological Oncology at Dana-Farber Cancer Institute, and also a member of the Tina's Wish Scientific Advisory Board. Definitely excited to ask Drs. Chowdhury, Elias, and Liu some questions. After that, similar to the main session, we'll open up to the audience for additional Q&A. If you have a question, same format as before, you can type it into the chat so that everybody can see it, or if you want to direct it towards just myself, just hit the drop-down menu, select Tyler Harrington. At the end, I'll go through 4 or 5 questions from the group. So let's get started. Dr. Chowdhury, you're up first. I think I speak for everyone. I say how exciting it was to learn about the progress from the MID study. I'm still learning about it myself. I mean, fascinating. As the doctor on the call, who's also a clinician, please tell us why or how you chose to go into the field of ovarian cancer research.
Well, I'm not a clinician. I'm a scientist. I'm a basic lab scientist. That's Dr. Elias, who's the clinician, who's the doctor on the call. So I can tell you how I went into ovarian cancer. I think it's easier if Kevin tells his story on that. But my story on that is I actually work on DNA repair in my lab, and the BRCA1 and 2 genes, their actual role in our body is to maintain the DNA, to make sure our DNA, our genes stay intact, they don't get mutated. So I work in my lab on the basic biology of how these factors work, how does our body maintain it. But as I got more into it, at some point we started looking at the consequences of what we call BRCA positive on the clinical side, working with people like Kevin and Panos Konstantinopoulos at the Dana-Farber. And that's how I got motivated to really move our work, not just do the basic work, but also take it a step further and do the work in terms of the clinical application.
Got it. Thank you. That's super helpful for the audience. Dr. Elias, you're next. One thing we didn't do during the main session too much was touch on the subtle signs and symptoms of ovarian cancer, although we did hear some things through several of the videos. Can you please go over those subtle signs and symptoms and some of the risk factors so people are more aware?
Absolutely. So The reason we think of ovarian cancer as kind of a silent killer is that the symptoms are so non-specific. The things that we typically look out for are bloating, loss of appetite, unexplained weight gains, particularly in abdominal swelling, urinary frequency, and pelvic pain. Those can all be signs of ovarian cancer. Unfortunately, those can also be signs of almost anything else going on in the abdomen, which is what makes it so difficult. So it's quite common that people will be evaluated for acid reflux or for irritable bowel syndrome or gluten intolerance or maybe urinary symptoms before they eventually get diagnosed with ovarian cancer. So that's why it's very important, particularly for symptoms that are persistent, that ovarian cancer gets raised as something that is a possibility. As far as the risk factors for ovarian cancer, the most important risk factor is a family history of either ovarian cancer or, as I mentioned, also breast and GI cancer. So any cancers, particularly, it can be from either side, from the father's side or the mother's side of the family. This is not something that just has to be on your mother's side of the family. As well as women who have never had children are at increased risk of ovarian cancer. Women who have been pregnant, who have breastfed or have ever used birth control pills have much lower risks of ovarian cancer. So women who have not had those experiences are at higher risk, but each of those things, pregnancy, breastfeeding, and birth control pill use, do significantly reduce the risk of ovarian cancer.
And if someone does have a family history of ovarian cancer, and they learn that they have inherited a genetic mutation, what are the next steps that they should take?
The first step they should do is call Ryan and see if they're eligible for the MIGHTY study. That's one. But they should meet with their clinician to discuss what a cancer surveillance program for them should look like. So obviously we're very focused today on ovarian cancer, but for women who are carriers of genes that predispose to breast cancer, like BRCA1 and BRCA2, that is a situation where early detection works quite effectively. So those women get more intensive screening to diagnose early breast cancers. So women who might have a history of what's called Lynch syndrome, which has a risk of both ovarian cancer and colon cancer, would get colonoscopies at an earlier age and more frequently. So it's important to have a discussion about cancer surveillance for all the cancer types. For ovarian cancer specifically, it's a discussion about what someone's plans are as far as their families, and does it make sense for them to consider a risk-reducing surgery to prevent ovarian cancer, which is usually removal of the fallopian tubes and the ovaries, obviously depending on a woman's age and her future fertility desires.
Thank you. Dr. Liu, are you in the room?
Yeah, I'm over here.
Hi, how are you? I couldn't see from my view. Good to see you. As a medical oncologist, what advice do you have for women in terms of staying on top of their gynecological health? How can women be proactive?
Yeah, I mean, I think that certainly in general, I think that it's really important for all of us to stay on top of our health maintenance. It's been very hard, I think, for many of us, especially in the past couple of years with the stresses of COVID and everything else going on. It's easy to let things slip, but it's really important to stay in touch with our doctors to keep up with health maintenance. For women, that includes sort of your annual visits with your gynecologists and exams. For those women in the appropriate age to do the pap smears as recommended, and there are recommendations for those. I think as Kevin alluded to, I think the other thing that's really important is to listen to your body. The symptoms of ovarian cancer, for example, can be very subtle, or they can be things that can get confused with other non-specific diagnoses, and things that persist are worth an additional discussion and a workup and a question to your doctor. Could this be? Because sometimes that's enough to trigger that workup that sort of gets you to the next step. And so I think that's the important way for us to be proactive and stay on top of our health, and be in touch with your physician. Don't be afraid to ask questions when something is going on.
Thank you. Let's see, Dr. Chowdhury, why do you think it's important for research scientists to collaborate with clinicians?
Well, I think the work we talked about today epitomizes it. So I work very closely with Joyce. We are working on endometrial cancer where Joyce is leading a big project. Obviously the work with Kevin we talked about. It's just about learning, learning from each other. I learned so much from my colleagues like Joyce and Kevin that, it really shapes our research, because sometimes we get too caught up in our own ideas of what is interesting, but then, it moves us further away from the clinic, from actual application. And there's no reason for that. If you have that constant dialogue, you just then can do the same exciting biology, just do it in a more directed way, which has chances of getting applied is a lot more. So I find it absolutely educational. I learn from them, they inspire me. And I think this is one of the greatest strengths of Dana-Farber. We have that, and the Harvard Medical School in general, with Kevin being part of both Dana-Farber and Brigham. So I cannot emphasize how lucky we are to have this environment.
That's great. Back to Dr. Liu. When your patients come to you asking about the pros and cons of participating in a clinical trial, what do you tell them?
So I'm a medical oncologist, so oftentimes the trials that my patients are participating in are treatment trials. And I always tell them that, they do come with pros and cons. The pros are that they are opportunities. They are opportunities to have access to drugs or medications in development that otherwise would not be available, that attack their cancer in new and different and novel ways. And we hope actually bend the curve. They change what the cancer would have done if we were limited to only the chemotherapies or the treatments that currently are FDA approved or on the market. And so they really represent opportunities. The flip side of the coin is, because they are new drugs, there are unknowns. There are sort of risks that come with the unknown, that there might be side effects that we don't anticipate. And so those are the pros and cons of participating in a therapeutic trial. But then there are also sort of trials like the MIGHTY trial, which I think are not only sort of opportunities to learn more about yourself, but also opportunities really to build, and this is true for all trials, to build the knowledge that we have to help not just yourself, but women everywhere. And I think that's a real pro of clinical research, that we can build on the things we know, we can contribute, we can learn, and we can really advance the science so that we have early detection, so that we aren't diagnosing women in late stages where their options become more limited.
Thank you. And last preset question here before we go to more Q&A from the audience. Dr. Elias, what are some other scientific discoveries or investigations in the pipeline around gynecological cancer research that we should be excited about?
Well, there's been a lot of exciting developments on the therapeutic angle. Certainly, there's been some recently newly approved treatments for cervical cancer. There's been Dr. Liu has been at the forefront of some of the new therapeutic treatments for ovarian cancer. So we've seen a lot as far as for women who have cancer, extending their quality of life and their survival. I will say that when it comes to early diagnosis of preventing cancer, there actually isn't a lot else on the horizon. I think the MIGHTY study right now is really the only study that's prospectively looking at women across the United States for an ovarian cancer diagnostic. So it's not like there's a deep pipeline out there. Really, this is it when it comes to really trying to move early detection tests into the clinic.
Thank you. I'm not seeing any other questions here from the audience, or now I'm getting them. Okay, here's one. Should you get the BRCA testing done more than once? And I'll open that up to whoever wants to jump in to answer.
So it does depend on when someone had the BRCA testing done. So the BRCA testing has evolved over the last few years, and there's multiple types of BRCA testing. So there's very limited BRCA testing, which only tests for 3 of the most common BRCA mutations, and then there's more extended BRCA testing. which detects for a broader range of mutations which might predispose to ovarian and breast cancer. So I would say if someone's only had very limited testing, or their testing was, say more than a decade ago, if they have a family history or a personal history of cancer, they should get retested. It does not have to be repeated that frequently, but when the tests themselves have changed, it is worth repeating.
And just to build on what Kevin was saying, I think there's BRCA testing, and then there's general sort of genetic testing for other mutations, including BRCA, that can predispose to the risks of cancers, including ovarian, breast, and other cancers. And so BRCA testing, if it was done a while ago, was oftentimes just BRCA. And over the past few years, they've evolved into what's called panel testing, which is a panel of genes that can be anywhere from about 13 or 18 genes to somewhere around 50 to 60 genes now that are tested all at once. And so that's where, if limited testing was done previously, now we know that there are other genes that can contribute to risk of ovarian cancer, and it may be worthwhile to repeat that testing if in the past only BRCA 1 or 2 testing had been performed, for example.
And along those lines, the MIGHTY study is including women with those much less common mutations as well, which is actually going to add a lot to our information about what the risks of cancer for those genes actually are.
Kevin, you have psychic powers, because
I
that is the question that's in the chat right now.
So yes, other mutations, yes. So that would be mutations like the PALB2 mutation or BRIP1. These are mutations that families now are getting diagnosed with because of panel testing. They're not things that used to be in standard panels, and we are certainly including them in the MIGHTY study.
That was perfect. I didn't even have to read it because everyone's getting chat messages. We do have a couple messages that were sent directly to me rather than the group. So going back to the main session where there was a lot of discussion about focusing on women with high risk, how do women know they are the ones at high risk, and how widespread is genetic testing?
So knowing whether they're high risk is going to be based on a conversation that you should have with your doctor. So again, a good family history. Are there other individuals in your family who have had cancer as a start? And then certainly any woman who herself has had cancer, it's worth a discussion about whether that cancer might predispose to other cancer types. A lot of times when I'm having conversations with patients, maybe the cancer that I saw them for has been adequately treated, but we talk about genetic testing to figure out what other cancers they might be at risk for and make sure they get adequate screening. As far as the availability of genetic testing is quite wide now. In fact, it's become a lot easier because now we are able to do virtual genetic counseling. So you can meet with a genetic counselor in a Zoom session, kind of like this, and they can send a kit to your house that you spit into a tube, and they do your genetic testing that way. So it's actually become quite a bit easier.
If I can add to that, one thing we are hoping, because one limitation of testing for specific genes with mutations is that right now in the labs, we discover new genes every day which could contribute to the BRCA pathway. So one hope we have, and it's a bit of a, I would say a bit of a fantasy, is that the microRNA test can actually become also in some cases a test for whether you're actually high risk or not. Because we are, we have got a large number of women who are normal, have no tumors, but they are from the high risk families with different kinds of high risk. And then we have some who are from normal women with nothing. So if we can, and we already have a set of microRNAs that seem to be able to distinguish them. So this holds true. One could imagine a microRNA test being just a test, a blood test telling you, maybe we don't have a gene corresponding to why you are high risk, but something is showing up in your blood, which suggests that you might be high risk, so we should take a closer look. So that's another application we are looking at and working on. So just a thought.
Great, thank you. And I guess why don't we take one last
Tyler,
one?
sorry, I just,
Sure.
I don't know if you see them, but there's a gentleman whose name is Bob who has been waving at the screen.
I got Bob's question. I'll address Bob's direct question.
Oh, no, I can't. I'm only seeing the
Okay.
a few in my top speaker view here.
So Bob wanted to know how our test compares to a test that's offered by a company are being developed by a company called Grail when it comes to ovarian cancer. So I can address that one. So the Grail test is a pan-cancer test. So they're looking at all types of cancer simultaneously. I think more than 50 at last count. It's not a test for ovarian cancer specifically. What I can say is that ovarian cancer has not been one of the priority cancers in their panel because it's a relatively less common cancer than the other cancers that they've been focused on. So they have reported a small amount of data for ovarian cancer, but given the very, very, very small number of women with ovarian cancer that have been in their studies to date, it's not anticipated that ovarian cancer is likely going to be one of the cancers that they focus on.
Thank you.
Thank you for pointing that out, Dr. Liu. Appreciate it. I could not see Bob on my screen. But with that, I think that takes us to the end of the Q&A session for now. So I personally wanted to thank Dr. Chowdhury, Dr. Elias, and Dr. Liu for all their time tonight, and also for the great work they're doing and how impressive it is. It's kind of mind-blowing for someone like me, that's for sure, to just even hear any of this. So thank you all so much for joining and for everyone for participating on the panel as well. Before we wrap up, just a quick update on the fundraiser. So exciting news, we've exceeded the match challenge and have raised $20,000 tonight towards the match, which takes us to a grand total of $90,000 through the Tina's Wish Foundation for this Boston Gathering event, which is outstanding, especially given we're doing it on a virtual basis and unfortunately couldn't be together tonight. So incredible from everyone, and thank you again to the doctors. That about wraps the evening here, and we appreciate everything. So thank you all and enjoy the rest of your nights.
Thank you.
Thank you very much.
Thank you, everyone.
Thanks a lot.
Everyone, good to see you.